Invite the moderators for the session, Dr. Sudeep S. and Dr. Varun Bia. Dr. Sudeep S. completed his BDS from Annamalai University in 1994 and MDS from Rajiv Gandhi Institute of Health Sciences in 2001. He has also underwent training in implantology and aesthetic dentistry and orofacial pain. He is the professor and HOD of the Department of Prosthodontics and the principal of BMS College of Dental Science and Research. Dr. Varun Bia completed his BDS from Rajiv Gandhi Institute of Dental Sciences in the year 2006 and MDS from MGI University, Tamil Nadu in 2010. He is also a fellow of the Indian Association of Oral and Maxillofacial Pathologists and is currently working as a professor in the Department of Oral and Maxillofacial Pathology, BMS College of Dental Science and Research. Now I hand over the mic to Dr. Varun and Dr. Sudeep for introducing the speaker and to moderate the session.
Thank you.
Thank you, Gayatri. A warm good morning to all. Dr. Henry, he graduated from NUS in 1996. He received his post-graduation degree in 2002, and he's a member of Royal College of Surgeons, Edinburgh. He specializes in prosthodontics and implant dentistry. He's also working as a visiting faculty in National University and Hospital at the NUS, where he studied. He's deeply involved in education. He's a board member of Dental Implantology Postgraduate Program and also a regional trainer in University of Frankfurt. I welcome you, sir, for this session, and I thank you very much for accepting our invitation for being here. And I also welcome our chairman, Dr. P.S. Taha, to just have an interaction with him. Taha, sir, please.
It's mute.
Welcome, Dr. Henry,
Hello,
for joining us for the International Faculty Week. Hope to see you soon in person. Thank you.
Pleasure.
Please unmute.
So you can start the session. You can start sharing the slide. We will start the session. If anybody has any doubts, you can put your doubts in the chat box, or you can personally WhatsApp to the moderators. We will address the questions at the end of the session. Thank you.
Okay, I guess I'm good to go. I'm ready to start.
Yes, sir. Go ahead, sir.
Okay,
thank you.
Thank you very much. Okay, first of all, thank you very much. I'd like to thank everybody, especially the dean and also the fellow professors, for the very kind invitation to be part of your program. And it's surely an honor. And I must say that before I want to proceed my lecture, I will say that I have a very strong connection with my Indian colleagues. And since my time with SRM College, I have met a lot of wonderful and very brilliant scientists, including your professors in the universities, in yours as well. And I have the honor to speak to many of them, and I'm truly grateful for this opportunity. So let's go to the topic today of our discussion. I'm going to spend a bit of time talking about going digital. I think a lot of the digital concepts is not new to many of you. However, I like to use today's opportunity to show you the reason why, as a prosthodontist, that I should adopt a digital solution, even though I have been doing the conventional way and having success with what I do. And I will also share with you what are the pains and the discomfort I have to go through to relearn some of the stuff that I'm familiar with all over again. And I'll share with you my clinical adventures, cases that I have done. In fact, I will also show you some very interesting multidisciplinary cases, and hopefully I can change your mindset on what is your view of digital dentistry. But before I start, I'd like to give a few acknowledgements. These are the people I work with, and Dr. Simon, you have seen him earlier on in his lecture. He's one of he used to be my student, and of course now that we are working colleagues and we are doing partners in crime in many of the training that we do and also the courses that we run together. Dr. Jun Huang is a very talented orthodontist, and his special interest is using aligners and digital dentistry. And you will see many of these cases are actually co-managed between the two of them and myself. And of course, myself and Dr. Simon and Dr. Chun Huang being KOL of 3Shape, we have been very deeply involved with them in terms of development of concepts and with other centers as well. And we are able to show you some of the cases that we have done. Then just before I start my lecture proper, I hope you just indulge me for a couple of minutes. I would like to show you a very short video. This is the video.
Here's to the crazy ones, the misfits, the rebels, the troublemakers, the round pegs, square holes, ones who see things differently. They're not fun. They have no respect for the status quo. You can quote them, disagree with them, glorify or vilify them. But the only thing you can't do is ignore them. Because they change. They push race forward. And while some may see as crazy ones, we see genius. Because the people who are crazy think they can change the world, but the ones who do.
So I put up the video, and you know that the video is basically talking about change, about people who dare to make the change. And to make the change can be very painful. You can be misunderstood. And in fact, very often you will be prosecuted. And I must tell you that when I decided to move from what you see in this screen, a conventional way of how I do my conventional cases, which I am already very familiar with, things that I have done for many years. And these are cases that I've done for more than, already follow up for more than 16 years, from the time we do a diagnosis to the time we gather all our important data with impressions from x-rays, and then towards the execution of the procedures, following up in terms of checking the aesthetics, the phonetics, and the bite. All these things that we know as a prosthodontist when we do our rehabilitation of our cases. We know that then from those proceeding forward, we are very, very familiar with the way we've done taking impressions, taking our bite registrations, making our lab cases, understanding our materials, and playing with our materials to create the final prosthetic work. And all these things being so painstakingly done requires a lot of precision. As you can see, there are multiple steps, and each steps will trigger a different inaccuracy, in fact, a challenge. And it will be compounded if we do not learn how to manage it. And as prosthodontists, we are truly understand this. And finally, when we're done all these things, it's not the very end. It is the patient that we are trying to give the work. So it's important that what we give to the patient is something functional, aesthetically pleasing to them, and also should not create any discomfort, and they're able to function with this. So this case, this patient, I completed this work for 16 years. So you find that the patient have a very stable situation, and we have done it conventionally, the way that we've always been doing. So why should I change? Why is there a need for me to change when I've done things right? Perhaps we cannot ignore the fact that digital is here to stay, because things can improve. As I mentioned, I showed you in the video earlier before, we just have to learn to change, and we cannot ignore the change. We cannot just accept things as it is. Things move on, things have to develop, and that's why there's progress. And that's why I put this slide simply because I like the word rebel. Because Albert Einstein was a rebel, to not believe the status quo, to not accept the norm, because that's what we are as people who are in the institution, as researchers. So what we have to do today is to look at the digital from another perspective. Can we now amalgamate both digital to the analog situation that we are so familiar with? Well, we have accepted that in conventional everyday devices. In the early days, we can see that we can have a phone with a simple task. And then the 1973, the beginning of a digital era, where we now have a portable device. And this portable device led to leading subsequently to a smartphone. And now we know today smartphones are everywhere. They come in different forms. They are all fighting to show you who is better and who can do better things and more things, and they are able to amalgamate things together. We accept a change in technology in our everyday life. We should also start to accept technology in dentistry. And it's something that we as dentists must move on. And this is something very difficult for me as a prosthodontist, as I mentioned to you earlier on. I had no problems the way I'm doing things, but I believe we can do it better. So there are many choices available to us in the digital technology that we have today. We have many scanners in the market. In fact, we have a lot of milling machines and so forth. So we are actually spoiled for choice. In fact, for those of us who are practicing today, we have the privilege of playing with this. Perhaps us as clinicians, we have more chance than the students, but I'm very envy the students. We will all understand this. The students begin already on a foot, straight away on the step of doing digital, while we are still trying to learn. So, and especially even for people like myself, dealing with a computer is already difficult enough, and digital can get very challenging sometimes. But nonetheless, it is something we cannot ignore. So in the past, we are taking impressions. Of course, today, we can just use the digital scan. In the past, we used to keep a lot of models. Today, we don't have models. And in fact, the models itself, you don't even need to do all your surveying, because the surveying is done digitally. We block out our undercuts digitally. Everything is done really fast. You take away a lot of steps of pouring models, distortion from impressions, distortion from the stones, and then your impressions having bubbles and having to trim it. And all these things create a lot of add-on inaccuracies. So how do I choose? Why I choose a certain software over another? Let me just put it as a very simple case in point. If I am now using a digital device, and I use a digital device that from the very beginning, software works in a full spectrum. When I say a full spectrum, it means they're able to do single crowns, the complex work, ortho, they can do splints, they can do implant planning. And now they can be cut down into piecemeal, targeted spectrum, which is perhaps some dentists don't do ortho, they do implants, they buy a certain software for the targeted spectrum. Well, I would believe that such a system would be more accurate and more well-planned, because in the beginning, they have the ability to do the full spectrum. Whereas other systems, they started off with specific or targeted spectrum. And now they're trying to expand the repertoire of the softwares so that they can do more procedures. And then that is when I'm truly concerned about them putting it together, making it seamless. So based on what I just explained to you, it is a reason why I choose a certain type of software over others. But ultimately, it's up to the comfort of the clinician to decide. And this is what I was trying to explain. So this is how for example, 3Shape, how they started off, because that's how they have a software that deals with all kinds of prosthodontic procedures, including dentures, overdentures, frameworks, and so forth. And now you can simplify by getting a subsequent different type of software that's targeted. So I'll rather depend on a system that give me these benefits. So in a traditional workflow, we will see that there is the procedures that we need to do, pouring of impression, and so forth. I mean, this is all straightforward. All these things are done, and each step creates a form of inaccuracy. Whereas in the digital phase, we have a digital scan. We have a digital scan, and all you need to do is scan, and then you send your impressions digitally, and then you print it. You cut a lot of in-betweens. You cut away the need for wax patterns, pouring, investing of your wax patterns, and then castings, shrinking of castings, problems with your material, and so forth. All this is cut off, reducing the inaccuracy, reducing the chance of more steps, and therefore the chance of more error. So what is necessary in all softwares from the very beginning is a design. From the design, it is transferred into execution, and execution will require a system in between, the interface that helps to transfer from the design into the execution. And that is why you need to get a system that works and bridge and marry both sides together. And this is critical, especially if you are setting up a full digital workflow in your practice. So as I mentioned to you before, I like a system that allows me a repertoire of procedures that I can use and all marry in the same platform so that I can interswitch the different platform for my patient treatment. Very much like a dentist sitting in his clinic, having a choice to look at different implants, look at treatment planning, look at ortho, look at smile design, and to bring it together to the patient, like how we do it on the models. So we have a very seamless situation and platform for us to work with. So the key of everything is the software. So it is important when you want to choose a digital platform in your practice and do this in your clinic, you will need a good software to support your treatment. Gone are those days when we have very interesting impression techniques, impressions that we put too much impression material, a patient feeling very uncomfortable. And even the early days in the digital phase, when we're doing our digital work, we have to spray a lot of this dust on our patient's teeth. They are uncomfortable. Sometimes the patient will cough, it's choking them, and you pay extra money to spray all this paint. And when you spray all this dust, the problem is that when you spray too much, it affects the accuracy. So can we go away with all these things, take away the discomfort from the patient? Certainly today we can. All these things have been overcome already. And traditionally, we also know how difficult it is to take full mouth impressions. In our midst, if we have our MDS prosto students, you know how difficult it is to do a full mouth impressions, capturing all your preps at one time and missing some of them can be very frustrating. And then you find that you cannot repeat them just on one tooth. You perhaps have to do do a whole arch or part of the arch altogether again. So we understand how difficult it is, and then plus mounting of the models. So these are the challenges we face, and this can easily be overcome with the digital platform. So the good thing about digital, it allows us to also validate our preps, especially when do multiple preps. It allows us to check our undercut immediately, so we can actually get rid of it or we can eliminate it, because we do not want to pour our impressions only to realize that we have problems in our fabrication. So this is the beauty of it, which is what's very attractive. And you know that if you get undercuts, you're not going to have a crowns. They're going to be very fitting, or perhaps you might have even open margins if you cannot manipulate or you cannot overcome the undercut area. The other beautiful things about digital, it allows us to validate our prep reduction. It allows you to check if you have done enough preparation, enough space for your restorative material. So you do not have to pour your impression to only realize that it's too late, or you make your provisionals only to realize that it's too late. You can scan, you can check first, and then you can go back and you can prep again in areas that you're deficient in your preparation, and then you can just then finish and retake and take over a scan over the old area, and then you get a refinement of your impressions. So the advantage is that it gives you a lot of patient comfort. It lessens your clinical visits. And then clinician is also a lot more comfortable. You do a lot, you can repeat easily. You can touch up your procedures easily. It like I mentioned to you, it allows you feedback and modification. And without models, without a lot of bytes and things, it saves you a lot of space and cut down the cost. The major disadvantage for me as a clinician who have been practicing prosthodontics for more than 20 years, this change can be very painful. There's a deep learning curve, and it's always a little bit difficult, especially with computers, but the softwares are so seamless nowadays. In fact, software glitches are very rare, and the only difficulty I feel, and especially for us as Asian, we don't have big mouth and we don't have big teeth. So we find that even for some of the scanners, some areas, especially the second molars, can be quite challenging for us to take impressions. And in some cases, depending on the kind of material you choose, there might be a especially if you do a same-day crown, there might be limitation of materials for you to do same-day crowns. And of course, if you're doing same-day crowns, you also need you have to invest in extra equipment, for example, a furnace, if you never had one in your clinic. So I want to quickly now use this moment to show you some of the cases that we do in our practice, and I'll use it to explain how we execute with the digital platform. But it is really one of the most versatile systems that we have experienced so far. We are able to do a lot of these procedures in our clinic, and we're able to do this for our patients. And you do not need to have multiple models, because an orthodontist take a model, then a prosthodontist takes a set of models, and so forth. So there's only one model, and that model is a digital model, and it serves both purposes. In fact, I can just transfer the model that my orthodontists have done for my restorative use or for my implant planning. So you find that you do not have to do a lot of repeats. You do not have to put a patient through more discomfort, and you can communicate with your dentist easily in your practice or out of your practice, as long as you have the same platform. So these are the things that we can do today for our patients. I even use this to educate my patients. I show them a smile design instantly on just taking up the photograph of the patient, and then we just basically do a spot on site smile design for the patient to show the patient roughly how she will look like or he will look like with this new smile. Of course, the same-day crown can be done, and it's certainly something that some patients will find it a lot better. As for yourself as a dentist, using a one-day crown means that you can open up your clinical sessions for other patients. Perhaps it can make you more, perhaps better income or even more productive. Let's look at first digital planning and diagnostic wax up. Traditionally, we know how difficult it is, right? In a daily practice, if you don't do it properly, you encounter problems like that. When I saw this patient, I was shocked. I mean, she had an instant smile makeover, that's what she said. And when we saw the patient, I go, wow. I find ways to hold back my reaction, but this is unfortunately cheap makeover done by these were done in some of the perhaps I think one of them was done in Thailand and the other one was done somewhere else. I cannot remember. But the key is not so much of how it looks like. I think in the midst, if you're periodontist, you will know that this is totally not cleansable for the patient, and we run the risk of not being able to clean, recurrent caries, micro leakage. A problem, perhaps a few of these patients have already had pulpal involvement, and worse, a periodontal disease that might set in, and this is going to now subsequently trigger a very difficult treatment plan for these patients, because all the basic principle of implant restorative interfaces were all violated. So you find that when there's no plan, it's always very difficult to execute your cases carefully. And I'm sure Dr. Simon earlier on will have already explained to you and show you the importance of treatment planning. So what we do for these kind of cases is basically you need to do a mock-up, right? Mock-up for patients, traditionally, we know what we do. You take an impression, you do a diagnostic wax-ups for your patients. You can then, from the diagnostic wax-up, you can now tell your patient, this is how your teeth will look like. Perhaps when you look at the teeth, they tell you, doc, maybe I want my teeth a bit longer here, a bit shorter here. Can you change the plane and so forth? So if you now take a diagnostic wax-ups for anterior teeth, upper teeth, you take a face bowl, you take your impressions, you mount a case, you do a diagnostic wax-ups, you do your putty to do a trying pattern, and this is what you can do. You do an aesthetic trying for your patients, and then you can tell them, look, this is how it might look like. This is where you need to do the correction. Perhaps your lateral incisors or centrals are a bit too short. We can do a crown lengthening to give it a better aesthetics. Nonetheless, this is all talk, right? You just talk to the patient and tell them and show. But it is not the same as in a digital. I can just pull the crowns longer, shorter, and instantly I can give the patient a different outcome and a way for the patient to decide better. Ultimately, the patient always needs some form of physical checks so that they can actually visualize what they are paying for. So you can see the top is before, the lower is after, to show the patient this is how you look like if you do veneers, or you can do composites, or you need to do a bit of crown lengthening and so forth. So you use this traditionally as prosthodontists, as aesthetic dentists, cosmetic dentists, to communicate with our patients what needs to be done. And this can take quite a long time, because I told you before, you need to take your impressions and your bite and so forth for you to execute this procedure. So traditionally, like I said, like this case that I want to show you was what I did with the patient. Same thing, you take impressions, you take a face bowl, you mount the case up, you do all your diagnostic, wax up and so forth. And you put in your suck down, in this case, a matrix. You can just put it in, and with this matrix, you can now tell the patient, this is how your teeth will look like. We need longer teeth. And you can see from the matrix, the gingival level is a bit lower compared to the position of the collet margin, where I'm planning the gingival margins on my teeth. So we use this as a surgical guide. We do our crown lengthening for the patient. We did from 4 to 4. And then you try to position back the jig to make sure that you have sufficient clearance from the osseous contour not to violate the biologic width. After the crown lengthening, this is what the patient will have. And then you make a provisionals for the patient, so the patient have a period of looking at the aesthetics. We can do the adjustments, and we can refine our margins. And you can see on the on the tooth number 22, upper left lateral incisor, there is still not complete remodeling on the gingiva. There's still a bit of recession. So we can always go in and refine our preparation. So in this kind of cases, when we do the aesthetic try-in, we are also trying to assess both phonetics and also function for the patient. From here, after the treatment, we will be able to finish, and we can see when I superimpose the two pictures, there's lengthening of the crowns gingivally, but there's also slight lengthening incisally. So this is what we have achieved for the patient, and this is basically what the patient has after 8 years. So it's important for us to know that never forget that prosthodontic is not prosthodontics alone. It has a very close intermingle relationship with periodontics. And basically, we do not violate our biological tissues. So this is what we have done for the patient. And this is after 12 years. So you can see after 12 years, it's still having a pretty decent outcome. Oral hygiene could have been better, but nonetheless, we know how stable the tissue have been. And this is from a view from the patient. So digitally, we can do it a lot differently. We can do it on the spot. So what we do is we take a smile of the patient, we put a retractor, and then we take another photographs. And then when we align the two pictures together, we can then now put out certain landmarks, interpupillary line, the alar line, and also the commissure line. And when we put them in and align the face, we can then do the when we align the spots, as you can see, we take one photograph, smile from the other photographs, and we merge the two pictures together. And then now we can start to design the smile. So this is all done immediately. When you take a photograph, load the pictures, and do all this stuff. So you can give the patient roughly an idea of how the smile might look like, where we need to lengthen the teeth. She obviously knows now we need to do some crown lengthening of her anterior teeth to achieve the aesthetics that perhaps that she liked. So we can show her the before and then what we've done with the after. So the patient can then immediately see how she looked like, instead of you having to make a model, pour impression, make your face bowl, do your aesthetic try-in and so forth, like I showed you earlier on. So all these steps could be simplified. And with this, with the patient's mind, now the patient say, hey, I like what you've done. I like to move on. So let's get on with it. So that's when you can now scan intraorally the full arches, the bite registration, and then transfer this facial aesthetics into your clinical cases, onto the impressions. So we do it routinely for veneer cases. So this is a good one example, straightforward diastema closure. So what we need to do is just do a scan of both top and bottom in a maximum intercuspation. This is how they look like. And then after I prep, I take impression, the technician now plans. Okay, but this was done previously before for aesthetic trying. So let me go back again. So the technician will just do a diagnostic wax up. So you can see some part, especially you look at the distal of the upper right central incisor, I will need to do a bit of more prep because that area has a tilt to the teeth. So it gives you a very smart idea to know where the area you need to prep. But it's very easy to plan this. So what you do is the technician will design the crown for you. He will print out a model. This is what we call the trying model. And then you make a putty with like body and duplicate that as a putty matrix. And then you put it on and you can show the patient immediately, hey, this is the provisional and this is the length of the tooth. This is the side of the tooth. And then what you do now is you will adjust accordingly. You can say, the patient say, I don't like this part. You want to trim a little more. I want to change the line angle a bit more. So you can change all these things with chair side with the patient till the patient is happy. And once the patient is happy, you take a scan of this because it becomes your new blueprint so that it guides you in your preparation. So when you put it in, you see that there's some adjustment already done, some polishing done to show the patient, hey, this is roughly what we can do. Now, then that's when you prep. And you prep through the provisionals because that is where you know that it's an area, it's actual crown. So you prep through them. So you will not have a case of over preparation of the tooth or under, especially when you use a veneer burst. If you just prep directly on the tooth, very often you tend to over prep some area or even under prep at certain sites. So once the preps are being done, you take your impressions. Of course, remember they are just a scan. If you are not going to see your margins, the scanner cannot see your margins. If you have to put a retraction cord, put a retraction cord. It's not an X-ray machine. So this is what we're done with the veneers that's completed. We do an aesthetic try-in for the patient. Aesthetic try-in are done just with water layer on it to show the patient the contours and the color. And then we can check the fit. And this is immediately post-cementation. So when we cement the crown, you do not over-contour, remembering that you always need to make sure that you don't violate the soft tissue. I'm not sure if Dr. Simon has spoken to you about how to manage interdental papilla. It's not the nature of this lecture today to show you this, but I have many cases where we teach how to contour the soft tissue so that we do not over contour, but yet we can create very nice papilla. So this is immediately post cementation. The tissues are healthy, and this is very important. And this is what we have done for the patient after we completed it. Again, see the soft tissue, the papilla has already starting to remodel. And this is what we have. Another case, same thing. Patient came asking for, after that, she finished her orthodontics. She wants a change to a smile. Again, like this is her bite. A close-up view of her teeth. And obviously, she has a little bit of a tooth size discrepancy. So same thing, scan, smile design, wax ups, digital wax ups. And then what we do is print the models and make the matrix. And then we can do the immediate aesthetic try-in. So this is what we can show the patient again and again. We can show them. Moreover, today with the digital machines and digital scanners, you can do a live movement of the patient's teeth. So when you scan it, you can ask the patient to do the canine guidance or disclusion, left and right excursive movements and protrusion, and this will be recorded as a movement in the scanner. So when you now have a model, and I'm sure Dr. Simon, I think Dr. Simon might have shown you earlier on how the scanners can create this movement and how this movement can actually aid you in the design of your final crown. So we tried it in, we need some adjustment, so we need to do the adjustments that she wants. We will adjust it, adjust even the occlusion till she's happy, and then we will duplicate this with a digital scanner. So this is a protrusive. So once we've done that, we can go ahead and we can plan for the preps. So like I mentioned to you earlier before, we put the tampon with TEM material on, as I shown you earlier in the aesthetic try, and we prep through it. So you find that your preparation will not be done directly on the teeth, but rather than be through the material. So you know your reduction and how much you have to do. So the burr will go over the area, make sure that the burrs have go through 3 planes, collect. Remember that the tooth is not a flat surface, it has a curvature. So make sure that your wheels run in the different curvatures. And once you've done your preparation, you start to do your refinement. So once you're happy with refinement, you do your scan. Okay, so this is how it looked like with the scan. If one of the tricks that we've done, and I'm not sure if the university has actually mentioned this before, what we always tell our students when they do their preps around the gingival margins, and especially when it's close to the gingival margin, one of the very useful tool that we use is actually using the piezo tips. And the piezo tips actually can go around the margins, and it cuts the teeth very nicely, give you very crisp line angles without hurting the gingiva. So you take the bite registration as well, as you can see, you can take a left and right to make it more accurate. And this is the provisionals for the patient. So then now with the bite taken and the impressions taken digitally, the technician now design the crowns. So once it's being designed, then I'm happy, then we will start to mill, and this is how the blocks look like when in green state, unsintered yet. So after the sintering, we then be able to get the veneers. So this is the veneer post cementation. So the patient now have the veneers fitted in, and it will copy exactly the provisionals or the aesthetic trying that we've done for the patient. And it's a close-up view of the case that we have completed. So another view from the incisal view down. So you find that there's no over contouring, preparation is sufficient, and then tooth is not unnecessary trim. So we try to preserve biological tissues, don't violate biological tissues, and keep everything mostly in enamel, so you get the best bonding effect that you want to achieve. So from here, we can get to here for the patient. And now she has a new smile that she wanted. So this was where she started off, and this is where she ended. She's satisfied, even though I'm a little bit unhappy because I wish her teeth were a little bit more pointed, more triangular, but she wanted a strong angle. So I'm not able to convince her to try to give it a more tapered look to her teeth, give it a sexier look. But this is what she wanted. Important is what the patient wants. So what is the role of digital technology then in implant dentistry? Actually, it is something that is right now, everybody is still talking about it. And for me, it's not so much of doing it, but more for pushing the envelope. I would like to show you how we can push the envelope. Everybody in this room understand that if you don't put implants properly, you put implants in bad tissue beds, you don't put an angle correctly, you get a disaster, right? So what you will see in this patient is basically a long-term poor outcome. And is a patient that unfortunately does not deserve this kind of treatment, but it's very hard to undo this unless she's willing to have all the implants removed, and it's going to be very destructive. So important to put the implant in the correct 3-dimensional position. I will not elaborate this. I'm sure Dr. Simon has emphasized this a lot. So if you do not put the implant in the right position, we get a lot of very interesting prosthetic outcome, which very often we are just amazed. How did the patient can tolerate prosthesis like that? But most of our patients trust us. We owe it to them to give them something that can last. Traditionally, we use surgical stands. We know this already. All these surgical stands have a limit because it's just a stand. You still need to put the stand in the patient's mouth with radiographic markers and then take x-rays with it. So because it is just a stone model and you're trying to do something that look like teeth and put it there, but you cannot see any anatomical structures that may hinder or make your placement of implants impossible. So this is one of the difficulty with using some of these stands. And very often I always tell my colleagues, as surgeon, and I'm a surgeon myself, where many times many friends will use, they call this the pocket stand. I said, why is it called a pocket stand? Because it only stays in the pocket. It's not meant to be used because it's not practical. So this is going through all the trouble to make this stands for use, but actually not used. And this is such a shame. So traditionally, these are also problem is when we plan, it can be totally different. Where we want the implant to be can be biologically not achievable. So what happens is that when we do implants, it's the same thing. The traditional workflow will require a lot of phases, whereas the digital workflow will have simplified a lot of steps. They will have eliminated a lot of guesswork from our practice, because now they're able to marry the so-called impressions with the x-rays together. And it allows us immediately choose where to position the teeth and where it matters. Are the implants at the right position? Is it biologically correct? And also prosthetically, can we achieve the result? And furthermore, if you know from implant prosthodontics, is the hardest to achieve precision of fit. Each steps that we take will create different amount of inaccuracy, and implants are not forgiving. Say you can say what you want, that the bone is viscoelastic, it can only tolerate a very small amount of inaccuracy. So you find that in today's context, especially when implant systems become so precise, the machining is so powerful and you get very good fit, then it's even more painful to have a misfit in your superstructures. So all these things can be eliminated. Distortion from your impressions, distortion from your models, distortion from your framework, distortion from your porcelain firing, all will trigger a final distortion. And this can create a big inaccuracy. And even if there's a small inaccuracy, you're not able to pick it up, and then it becomes a long-term problem for you in terms of screw loosening or breakages of your superstructures. So what we are able to do digitally today is, I was trying to push the envelope. I'm trying to do a superstructure. So I took an implant level impression, but I create a screw retain abutment level prosthesis. So in other words, I should be taking my scan at the abutment level, but I took the scan at the implant level, choose the abutment to make my final prosthesis. In other words, I'm trying to ask myself, what is the threshold of the inaccuracy? If it's a digital scan is not accurate, I will not be able to just use the implant level to work on a on a abutment level, intermediate level with a superstructure. So there will be definitely inaccuracy of fit. So what we did was scan with the scan bodies, choose the abutments, and then you put on the gold copings and do the superstructures. So what we did was, from the lab, we now transfer the jig into the mouth, and with the abutments from the cast taken out, put into the mouth, and took the superstructures and verify the fit. So we are trying to look for distortion. So we were quite happy that we're not getting any distortion at all by doing the Sheffield's test. So at the end of the day, we just make the crowns for the patient. So this is what we can do. So prosthodontically, we can achieve the accuracy that we want, but more importantly, when we do, is a surgery that plays a big key, right? If you are able to place your implants as accurately, as straight as possible, that would be the best outcome. So when we take impressions, we know the steps that's involved. I will just skip this very quickly. When we can even, and the implant is planned with the prosthetic in mind. We always know that it is a restoratively driven implant procedure. It should not be surgically driven implant procedures, implant crown procedures. So we make the surgical guide, and from the surgical guide and from the planning, we have already designed the crown and the abutment. All these things were done before the surgery is executed, and then of course finish the procedure. So traditionally, these are the workflow. I will skip this for now because of time. The key is that in your design of all your work, it must be prosthetically driven implant planning. So for digital guided implant surgery solution, we know that there are a lot of guides available in almost all systems right now, and I shall not go into detail. So what we can do is, for example, a case like this, quite straightforward. This is a slam dunk. What we do is that we take a scan of the patient, and now I ask my technician to design the crown first. When she designed the crown with me, I position the crown for her. I say, look, this is where I want the crown to be. And then now is when we design where to put the implant. And when we put the implant, we can ask ourselves, do we have bone? Are we off alignment? Can we adjust the crown so that we compensate with abutments? I'm not sure if Dr. Simon mentioned this to you. In our practice, we always tell our colleagues, if you now need to do an angle correction of more than 15 degrees, 1.5, to your prosthesis, you're not going to have aesthetics. Because all these abutments that cause compensation with more than 15 degrees, very often you cause an overbulbous neck area, and you always cause recession of the soft tissue. So this is a surgical guide that's made, and the surgical guide comes with the sleeve. Some system comes with the sleeve, some system does not. It's up to your choice, and it's important for you to discuss the workflow with your implant vendor, and of course, you yourself must know the limitation of the system. The try-in, you can see that the fit is perfect because it's very easy to fit. In the tree-shaped scan, they will block out the undercuts for you based on the path of withdrawal of your prosthesis or your splints or your framework, and they will then print it accordingly. So now I tell my technician, hey, now we know where the implant is going to be, design the abutment and crown for me. So that's what she did. So we have both crowns and abutment ready before the surgery. They also claim that they can give you some color guide and so forth, but this color guide is as good as how good your technician is, right? You can give the best color guide, but if your technician cannot match it, it defeats the purpose. So this is the limitation. But what I can do, though, is to contour my crowns now, before the surgery, so that when I fit the crown on, I let the soft tissue heal the way it should heal around my crowns. It directs the healing of my soft tissue, not the soft tissue direct the shape of my crown. So once I plan it, I have a 3D view, I'm happy with it. I design, I get the crowns ready and the abutments ready. Then the technician will then cement this to the abutment because this is a tie, it's a screw retain, but this is a tie base. So the surgery is done, guided by the stent and also by the tools. As you can see in this, you can see this is a typical Asian mouth, and some of the prosthetic, the surgical guides available, the drills are so long, it doesn't work, which is why I find that the Asian systems somehow have thought of this. You find that you can place implants at the back, at the 6s, at the 7s, but I always have problem doing that with the European system because the drills are so long, it just can't fit into our Asian mouth. And you find that in the guide, there is a little groove. The groove gives me an indication of where my flat surface of my implant should face, and that allows my correct positioning or my final positioning of my implant. If once at the correct position of my implant, then when I put a crown, you'll be at the correct position. So the crown is fit on, screw tighten, and then I can just stitch around it. So this is how the soft tissue will heal. And this is a period of consolidation of the soft tissue and its screw retain crown. And this is what we have finally for our patient. And you find that the color is a little off, as you can tell. Obviously, my technician is not able to match the color that was given to me by the digital scan. So it's the same with other case. You can either do that way, or you can simplify it by doing a simple scanning at abutment level. You can still place your implant freehand, choose the right abutment and scan, get the margins, and then you can fabricate your crown. So all you need to do with a lot of the system today is you can mirror it. You just tell the computer system, please copy the other contralateral crown and transfer it over. It will be able to do it for you very easily. It's just this other crown, this digital crown is actually a complete duplicate of the opposite side. And now you can do all your contouring, shaping to your preference. So this is what we can see from another view. So what I want to do is I can remove my soft tissue, I can view it, I can tell myself, oh, it's over contour subgingivally. I can do all my adjustment. I can see where the areas that are over compressions. and I can just use a brush with my mouse. I can just rub over the areas to remove all these areas, and I can smoothen all the edges to give me the crown that I want to use as a provisional. In our concepts, I'm not sure if Dr. Simon mentioned this to you. For our provisionals, there are 3 key, very important factors. Number 1, we always open up the embrasure space, because every surgery, there will be surgical edema. If you don't open up the embrasure space, the papilla can get pressure necrosis. Number 2, we always under contour subgingivally. And number 3, at the mid-buccal portion of our crowns, we always flatten it out, because we want to allow soft tissue to heal. And if you have over-contouring, the soft tissue cannot grow over it. So we flatten it to allow more soft tissue to form. It's always easier to remove than to try to add later on. So this is the provisional for the patient. Color's not that great, but it gives the shape. And now we get more tissues than before, as you can see. Then now this is what I can do. I can start to now contour my crown, add a bit of composites, and then shape my gingival tissues. And when I add the composite, it shapes the gingival tissue. It allows the gingival tissue to now start to recontour again and change. And then immediately, I can add the composite to the buccal surface, as you can see. And 3 months later, the soft tissue would have moved to the level that I want. If you need some more, you can add some more composites and allow the soft tissue to mold. And you can copy this subsequently by taking your impressions and finish your crown. And this is what we can do very predictably with the digital. And of course, you can do this the analog way. And control would be a bit more difficult because you can't see subgingivally. And so this is the crown, completed crown with the implant for the patient, and this is the final result. Well, it could have been better. We still think that the color could have been a lot more matching, but because of the characteristic of the patient's teeth, it is a little bit more challenging to try to get it totally matching. So the patient is actually satisfied with this. I'm not sure she is satisfied or he's tired of me, but nonetheless, this is what the outcome has been for the patient. Lastly, I'd like to bring to your attention what we can do digitally, and I will end with this case. If it's a multidisciplinary approach, when you do multidisciplinary approach, where you involve more than prosthodontics, more than just surgical implants, more than just, it also involves orthodontics, it also involves perio. You want accuracy, you want precision. And as I mentioned to you, you want less interfaces, and this gives you control. So this is the patient that I had, and the patient said, hey doc, I need to change my smile. This is not what I want. My teeth are all spaced out. What we have planned for the patient from our smile design, we then show the patient, look, you need some orthodontic treatment. You may or may not need crown lengthening. Then once you've done that, all this tooth size discrepancy can be perhaps managed with porcelain veneers, and missing teeth can be replaced with implants. But can we do all these things collectively with a digital interface? Well, this is what I want to show you. So my orthodontist will show me what are the tooth movement that he wants to achieve and where the final result is going to be. He will discuss with me, is this space enough for you to put a veneer? Will the size be good enough? So this is essentially what he has done. And once he has achieved it, he will make a series of aligners. And aligners obviously give very good control. If you are an orthodontist, who understand the principle of aligners. And once he done that, he showed me, Henry, this is what I will give you. Are you happy with this? So I said, yes. So the patient started a series of aligners to move his teeth, her teeth. So this is the outcome of her teeth after she finished her last aligners with us. And this is the spacing of the teeth that we wanted to achieve. And we try to compare before and after. So we can see the changes that have taken place before and after. The teeth that have moved. Before is when it is the bluish color, and after is when the natural teeth color. So there's obviously a difference in the outcome. You can see how much of teeth movement we have developed for the patient to get the effect that we wanted at the end. And this is what we have. Top for the upper jaw and also the lower jaw. So after you've done that, we tell the patient, look, when we do a smile design, we ask the patient, do you want it to be longer teeth or shorter teeth, and whatever, we plan with the patient. And then you do your aesthetic trying. So the top one shows without crown lengthening, and the lower one shows with crown lengthening. And now the patient has a matrix done, and then you can try it on the patient and tell the patient, look, this is how it looks like without the crown lengthening, and this is how it looks like with the crown lengthening. And in this case, the patient decided that, hey, actually, I look quite okay without the crown lengthening. We decided that then we shall do it without the crown lengthening and minimal discomfort for the patient. So again, with that matrix, we made the template and we prep over it. And this allows a very intelligent reduction of teeth without over preparation, created the preps outline, and then we can scan. So once we scan, the technician will then now take what we have designed earlier on, beginning, and transpose this into the final model. So it becomes an immediate copy over. And the technician now has only to do very fine, small refinements to the final prosthesis. So the veneers are made, prepared for the patient, and then this is the cementation of the veneers. And this is the outcome we have for the patient. What's interesting though, is that I'm going to show you the next series of pictures. These are implant planning before we did our orthodontics for the patient. So this was done, planned, and the teeth has moved. These teeth are moved before the orthodontics started. This was given to me by my orthodontist because I told him this is the final position of the teeth that I want. And this is the surgical guide that is made on the so-called intended final position without the patient starting orthodontics yet. So we can plan. However, we need certain landmarks. The molars are not going to move. We use the molars as a reference point for us to do our alignment. So once we position our implant, we make the guide. So now the thing is, can this guide even fit in the patient's mouth once the patient finished her orthodontics? So this is how it looked like. You can see on the screen, the fit in the front area, the position of the fit of the patient's surgical guide that was made before orthodontics, fitted onto her teeth after orthodontics. So that precision allows us to know that if we know how to take all this information, marry them together, control, and there's precision, we can get accuracy. And this accuracy allows us to work intelligently. So a lot of things can be simplified and made better if we have a digital platform to work with. Of course, the digital platform has to be seamless and allows you to work through different disciplines together. So while technology is important, it gives us the cutting edge in terms of execution, convenience, and with time to come, certainly the cost is going to be reduced. But I would like to highlight to everybody in the room, biology comes first. That goes without question. So, and I hope to end with this key point to you. So the digital technology allows a stress-free surgical planning, correct implant planning, and control also of your prosthesis fabrication. And of course, these are a result of a good platform that allows you to work and eliminate the stages of inaccuracies throughout the course of your fabrication. All right. And the important thing is, if you work with any tissue, the biology is the key. You remember, never violate your hard tissue scaffold, respect where they are, respect your biological width, respect the patient gingival biotype. The gingival biotype affects the final outcome and long-term success of your work. The contouring and emergence profile will help to preserve the soft tissue integrity and also cleansability and health for the patient. The embrasure space management is key, not just for contours to shape the tooth, but also to preserve the papilla and maintain the papillar health. And of course, the tooth form must be unique to the patient, custom-made to the patient. Not everybody fits a square tooth. Not everybody looks nice with triangular teeth. So all these things are biology. It has to be respected. So with this in mind, I'd like to say thank you very much for your kind attention. I'd like to give also credit to the University of Naples, whom I am actually a teaching faculty at the moment with them, and also being a board member of CNAME, which is the South European, North Africa, Mediterranean Implant Association. With this, I say thank you very much for your kind attention. I'll be ready to take your questions.
Hello. Yeah. Hi, Dr. Henry.
Yes.
Yeah, it was a great, wonderful presentation here today. So in the chat box, there's no questions. I have a few questions for you, sir.
Sure.
The minimal invasive procedures in digital technology, what is your opinion about that in digital dentistry?
Okay, you're talking about implants per se. Are you specifically talking about?
Yeah.
You realize that in our practice, the minimally invasive surgical procedures, somehow there is a flag being raised. You realize in our cases. The reason why we raise our flag, which means it's not minimally invasive anymore, I would say, we will keep it as little as possible in terms of invasiveness. Why? Because number one, if you do it through your soft tissue, and if you're dealing with a patient who have lost a teeth for a long time, very often they have no keratinized gingiva. And if you now drill it through your implant directly through the soft tissue, very often you will agree with me, you are eliminating whatever little 1 to 2 mm of keratinized gingiva. You eliminated it, you cut it away, it's gone. And now you have implants in there, good position, perfect for you. But now you have non-keratinized gingiva around your abutment, around your crown. And this is, as periodontists will tell you, this is not a good situation. As prosthodontists, I will also tell you it is a bad situation because you are going to have non-keratinized gingiva that cannot protect your longevity of your pink framework. So we always raise a flag. I always make an incision in keratinized gingiva. Why? Because when I make an incision in keratinized gingiva and I separate them out, if you have keratinized gingiva, what heals in between? Keratinized gingiva. But if you now have non-keratinized gingiva, keratinized gingiva doesn't grow as fast. Non-keratinized gingiva will go over it. You have soft tissue healing, but you got more non-keratinized gingiva. It's still a defeat in terms of final outcome. So, which is why I have an issue with considering minimally invasive in that sense. If I answer your question correctly.
Oh, yeah, fine. Thank you. So, what is your opinion about X-guide technology in implantology? When it's a 3D dynamic guided procedure. I think it's noble. It's noble back as technology.
Is it navigational or?
It's a 3D dynamic navigation procedure.
Right. Right. I have no experience with it, but based on first principle, I mean, this is not new. It has been done many years ago, calling a navigational system. For sure. I mean, I have no issues with doing navigational control, but ultimately the key is treatment planning. Because when we are doing navigational, we are only trying to get reference points to know where we are positioning our implant, correct? But I don't want to plan it last minute. I want my crown positioning of the crowns at the correct position and plan it accordingly. I want to identify all my hurdles before my surgery. So I don't know. I don't know how does that particularly help my surgery. Yeah. But I'm sure it's in due time, this robotic surgery will definitely be something worth looking at.
And when we come to digital dentistry, digital impression.
Yes.
After preparation of the crowns and there'll be overhangings will be there, and like that, a lot of problems will be on the preparation. So, about in digital dentistry, whether that will be identifiable with the digital technology, whether we can identify it, overhanging and all.
Okay, so it can identify, because as long as you can capture the margin, in fact, with a mouse, you roll the mouse around, you can magnify it. It can show you all your preps. Very often, as a prosthodontist, I'm very proud of my preps, right? And then when you scan it and then you put it on the screen, you go, wow, I'm really that bad, huh? My preps are so bad. Because it actually amplify all your inadequacies in your preparation, which is in a way good, right? Because you can refine it and touch up and then scan over it again and then verify your preps. Yeah.
Okay. And one more question from me.
Sure, of course.
Sir, while preparation, there are chances of bleeding and all. So when you make a digital impression, whether it will, while making an impression, whether any discrepancies that can happen during impression?
That's a very good question.
Digital.
Very good question. So basically, if you're having a bit of bleeding because of the gums, either traumatized or because it was already inflamed, so it is critical that before you do your scan, you must be able to put your retraction cords. I generally do not like to use hemostatic agents. So because hemostatic agents, if you can recall, it has a pH of 1 to 2, which is extremely acidic. So what happens is that it etches your root, causing post-operative sensitivity, and it burns your soft tissue. So I'm not in favor of that. What, however, I like to do in our practice is that after I put the retraction cord, there will be obviously making sure you don't violate the biologic width. Then we use this thing called astringent. We use this called Texodent. It's a kaolin and some alumina salt over the area. So it is neutral pH, and it is actually also absorb all the edema fluid. And then you just leave it there for about 5 minutes. When you blow clean it, it's a very nice, clean environment to look at. Yeah.
Okay, then over to Dr. Varun for any.
Thank you so much, Dr. Henry.
Thank you.
We are so privileged to have you here, especially with the background of National University of Singapore, where we understand they practice the high standard of dentistry.
So do you.
When the presentation becomes very clear and interesting, we also get a lot of doubts automatically. So I have a couple of doubts from the participants and myself as well.
Yes, please.
Sir, from the basics, are all intraoral scanners are the same technologically? If it is different, which technique is better? And if you can add on, whether we can use a third-party software like ExoCAD and all. No, if you can avoid the softwares given by the manufacturers, is it possible, and how you can explain on that?
Sure. I'm trying to explain this in a nutshell, because if this question alone, I can take 30 minutes. In a very simplified form, scanners work differently. They acquire images differently. Image is the image, correct? What you see is what you get. It's basically a prism image. You fire light and it scatters back, right? Once the image is received, it can be received through a different technology. They are what we call confocal technology, whereby it goes through a pinhole. Well, there is another type of confocal and acquisition. That's through the days when we watch films. They call it active wavelength acquisition. No, that means that the pinhole is not in the center. The pinhole is spinning at a certain speed. So what it means is that while you move and scan, the pinhole may not coincide with the image acquisition. So you may lose some image, right? So when you lose some image, then the amount of image you get per second is a lot lessened. And that itself can trigger loss of information. Therefore, the computer using AI will try to stitch point A to point B, which can create a lot of inaccuracy. And the third one is what we call triangulation. And that is through the another system. I will not mention the brand, but basically the acquisition of the software, of the information is taken by the software, and they use this triangulation technique. You know how the spies will try to look for you. You make a phone call, they do triangulation. So triangulation itself is a very powerful software, bringing all the images and stitch them together. So it's not just the image per se in terms of acquisition, it's also how the image is being processed by the software. So I cannot exactly tell you which is better and which is not. I can only tell you it has only gotten better. Today, if you ask me the question, which one is better? My answer is, I think they're all the same in terms of their technology, because they compensate it through either a software or they compensate it through how the acquisition of the image. I hope I answered that question.
Yes, yes. So the next question, how accurate will be the milled internal connection of implant, abutment, compared to the abutment which is provided by the manufacturer himself? So
Okay.
whether it is, the accuracy is the same?
Okay, this is very simple. Always use the fitting surface from the manufacturer, full stop. Okay, there's a CAD CAM that is done by the manufacturer. They have already gotten the blueprint. Of course, if you have the information from the manufacturer, let's say you work with this Implant X company, and Implant X company say, hey, I will release to you the information of the dimension of our abutment implant connection area, okay? And you now have this information. The CAD CAM has the ability to do that. Because it's the same CAD CAM, they use it in their manufacturing of the implants.
Okay, okay.
Oh, so I hope I answered the question.
Yes, yes. If we have used a customized healing abutment, because back in Dr. Simon's talk, he was telling the healing abutment is always straight. So that also will affect, the biological tissue, because you have the implant connection being concave like a natural teeth, but always the healing abutment is always straight. So he was telling if you can customize the healing abutment also, it will be better. If we have used customized healing abutment, how we can scan it? Because the scan body is actually, it depends on what type of healing abutment the manufacturer provides. So if we can customize the healing abutment, but the scan body, will it fit to that? Or,
no, the scan body goes directly to the implant. It's different. The scan body goes directly to the implant. And when you use a scan body, it goes directly to the implant. And when you scan, you're scanning the scan body, and you're also scanning the surrounding soft tissue contour at the same time. So you captured everything. Do you understand what I'm trying to say? Let me just go back to the picture that I have, if you will indulge me a little bit. This. So when we scan, we are capturing not just the abutment and the margins, we are capturing the whole inner surface of the socket. We are actually capturing the whole emergence profile.
okay.
So we try to contour that. So like I said, the best customized healing abutment is a provisional.
Okay.
If I can put it that way.
Yes, yes.
Okay.
And so if we scan for implant processes using scan body, we digitally design and fabricate the processes. Is it possible to check the fit, because we don't have the model and we don't incorporate the lab analog into it? For the crown, it's okay. We can 3D print the model, but for implants, the lab analog, we are not incorporating. So can we try it before?
You could. They can still print out the model to try it. But I will tell you that from our personal experience in our practice, the case come back with the crown and the abutment. That's it. There is no model.
Yeah.
That I can say. But if you ask me whether I should do it this way or that way or not, I think it still boils down to your precision of your scanning, acquisition of your images, and your quality of your technician, of course. Yeah.
Okay. So to quickly, I'll finish 2 more questions from a participant. So that is related to the 3D shape.
Yes.
So when he tried to use the trio scanner,
yes,
the edentulous area seems to be very difficult to scan.
Yes.
So is there any powder or any coat for any?
That's a very simple trick. Very simple. When you scan, what they want is references, especially the lower jaw. you realize that when you scan even the upper jaw, the areas easiest to scan is the anterior part of the palate, right? Why? Because of the rugae. The rugae gives you references, whereas an edentulous ridge gives you nothing. So one of the tricks that we do, I use indelible pencil, I do markings on the soft tissue.
Okay.
That will give me reference. If you don't want to use an indelible pencil to mark for references, what you can do, you can actually use the, the block-out resin that you use for your whitening. And just coat it a thin layer, make some drawings and whatever you want, write some blessings on it or whatever. You scan it, it becomes a reference for the scanner to work. Try it.
Okay. Okay. Another one more last one.
Yes.
How good is Trioscanner for scanning metal components like abutments and metal restorations?
Right.
Which coating material is used before scanning the metal components?
Okay. It all depends on what kind of color it is. For example, if you are already using titanium that is color coded, then it's not an issue. However, if it's not color coded, what some people will do is slightly powder the silver surface so that it becomes a bit dull. So when you scan, you can see the images very clearly. What we have seen so far is that when I scan it, I try to scan with my surrounding area a little bit dim, not bright. I'll turn off the lab light or I turn off the clinic chair light and scan. Then you can capture it very clearly. Because the scanner itself is emitting light, and that light is throwing the image back to the system.
Okay. Thank you, sir. Thank you so much for your valuable comments. I request our beloved chairman to have an introduction and give the token of gratitude. Sir? Sir, you're on mute, sir. Taha, you are on mute, sir. Please unmute, sir.
Yeah, Dr. Henry.
Yes.
You are really an embodiment of knowledge in the digital dentistry. I really appreciate your, commitment and sincerity to the profession that you are into, and really love to see you soon. And thank you very much for accepting our invitation and spending so much of time. And the way you present the lecture is from the bottom of your heart. You want to, do something for our students. Thank you. Thank you so much. You are a great man.
Thank you very much, sir. I want to say a few words just to say that I'm very honored to be in the midst of everybody. And like I said, if any of you ever come to Singapore, please let me know. I'll be happy to host you. It would be a pleasure for me.
Singapore is the most loved country for me. Singapore and Switzerland. Yeah.
Thank you, sir. Thank you. So I would say thank you very much. And for the students that are graduating, my congratulations to you.
Thank you. Thank you.
And I wish you the very best for the faculty as well. I'm looking forward in the near future, if we have the opportunity to ever work together, it will be my privilege.
You're all welcome. Thank you. Thank you so much.
Thank you. Okay. Bye-bye.
Thank you, sir.
Thank you, sir. Thank you.
Thank you.
I also thank Dr. Sudeep S. and Dr. Varun Bia for moderating this session. That was the last session for the third day of the International Faculty Week 2021. I take this platform to thank our chairman, Dr. P.S. Taha, for giving us this opportunity, the esteemed speakers for the day, Dr. Henry and Dr. Simon, for their immensely informative sessions, the moderators and attendees for their participation. The sessions will continue tomorrow, the fourth and the last day of this extremely enlightening week. To start, we have Dr. Louis Clement speaking on surgical volunteerism at 9 a.m., followed by Dr. Ahmed. The session will be on laser and microleakage at 10:30 a.m. And the final session for tomorrow will be by Dr. Dana York at 12 p.m. on laser photobiomodulation. Requesting all participants to kindly assemble by 8:45 a.m. in the auditorium. We will now be winding up for the sessions for today. I wish you all a good day ahead and thank you.